Hey, this is Dr. Nick with the ECG Academy, and we're going to continue our discussion on premature beats. In this video, we'll talk about atrial premature beats. Now, we've talked about this action potential and the idea that most of the cells in the heart can reach a certain threshold potential that will trigger the floodgate and open up the ion pores in the membrane to allow depolarization to occur. Okay, in plain English, that means that if a spot down here in the right atrium reaches that threshold for whatever reason, that it can fire and then an electrical signal will propagate across the atrium and cause a heartbeat to occur. So we characterize atrial premature beats as, one, they're early, and the other thing is that they come from someplace else other than the conduction system, and so they're known as ectopic. We can recognize the fact that it's coming from someplace different by the size and shape of the P wave. As you recall, in a normal sinus rhythm, the P wave travels down and to the patient's left. And so if you look at lead 1 and if you look at AVF, the P wave is upright in both of those because if it's going down into the patient's left, it's traveling towards lead 1, and it's also traveling towards AVF. Remember, lead 1 is at 0 degrees and AVF is at plus 90. Okay, well, what if the signal is arising from the low right atrium? What's going to happen is the signal is going to propagate in a different direction. It's going to travel up and to the left. Now, lead 1 may very well remain upright because it is kind of traveling towards the left, but if it is coming from the low right atrium, then the signal is going to be going away from the feet, and anytime something goes away from a lead, it will appear inverted on the cardiogram. So that's how we can tell that the P wave is coming from an ectopic focus, and that it will be inverted in certain leads where it shouldn't be. Well, let me show you how that's supposed to look. Let's imagine this patient's in a normal sinus rhythm, and what you expect to see is a fairly regular P wave, and a QRS that follows with a fairly stable PR interval. And then you'll have a premature atrial beat followed by a compensatory pause. Let's take this apart step by step. The sinus rhythm, unless you have some degree of sinus arrhythmia, is going to be relatively regular. The PR intervals should be fairly constant. And the way I've drawn this beat is that the P wave clearly looks abnormal, because it's coming from some ectopic focus. It's premature because it lands sooner than you'd expect if you were just going to map out the sinus nodal beats. And the next sinus nodal beat occurs fairly well on time, resulting in what's referred to as a compensatory pause. Now, it's interesting because many patients will complain about the pauses feeling like their heart stopped for a split second, rather than actually feeling that extra heartbeat. So with a typical atrial premature beat, it's going to be early, the P wave's going to look funny. And one more thing, I took the liberty of drawing this with a PR interval that's a little bit longer than the underlying PR interval. And you'll often see that because if you recall, the AV node, which receives signals from the atrium and passes it down to the bundle branches, the AV node behaves in such a way that an early beat or rapid beats may not be able to pass down the AV node quite so easily, and you may get excessive AV delay with a premature atrial beat. You can even see first-degree AV block with some PACs, and if this beat occurs early enough, it may not even be able to get through the AV node at all. We'll cover that in the last video in this section. There's a little bit of vagary in terms of terminology, because some people will call them atrial premature beats, and some people will call them atrial premature contractions or atrial premature complexes. Some people like to put the P first. They call them premature atrial contractions. It all means the same thing. Well, there's some more terminology I just want to mention. Aside from premature beats, you can see something called a couplet, which means that there are 2 premature beats in a row. A triplet would be 3 premature beats in a row. Bigeminy means every other beat is premature, and trigeminy is a word we use to say every third beat. So this is every third is premature and every second is premature here. And I'll show you some examples of this later. Just to mention those terms before we get started looking at some tracings. Okay, well, here's the first tracing I want to show you. This is a real tracing. You can actually see there's real noise on this tracing. Remember, here in the ECG Academy, I'm making you ECG experts so you can look past the noise, can't you? These are tracings from real patients, not just drawings that you'll find in a textbook. All right, so let's look at the forest. And what you should notice is that the rhythm seems to be fairly regular, but if you notice this interval right here is shorter, so this beat is something we'll come back to. And then look at that, there seems to be a longer interval following that beat, so it looks like we have a premature beat with a compensatory pause, and then we're back to being fairly regular again until the very end, when there again seems to be a premature beat. Now, what's the first thing you want to look at are P waves. Where are the P waves? How do they relate to the QRS complexes? Well, I do see a P wave in front of this beat. There's a little bit of a first degree AV block. If you measure the PR interval, it's about 240, 280 milliseconds. And you have a P wave there as well, so it's fairly consistent. Remember, you can look at any lead here. You can see P waves up here and here as well. So there's a P wave in front of every beat. It's upright in 1 and it's upright in AVF, so we're in a normal sinus rhythm with a rate of just about 75 beats per minute, maybe a little slower. So here's the next normal beat, and here's the premature. Now, you want to look for P waves in front of the premature beat because that'll basically prove that it's an atrial premature beat. Can we see P waves? Well, we sure can. Now, here's a lesson I want to bring out, and I've mentioned this time and time again. When you look at a P wave, it tends to have fairly rapid changes in voltage. In other words, the slope of the P wave is pretty sharp. It's a kind of a spiky signal, at least compared with a T wave, which is more broad and slower in its rate of change of voltage. In electronic or physical terms, if you've taken physics, there are high-frequency components to this signal that relate to the rapid change in voltage, whereas T waves generally tend to be restricted to low-frequency signals. Okay, so you can usually see a P wave superimposed on a T wave because it looks sharp, it looks spiky, it looks like the voltage changes rapidly. Well, you can see that here very nicely. If you look at the T wave from this beat, it's very smooth, and if you look at the T wave from this beat, you've got this sharp deflection at the very end of it that's clearly negative, and in fact, you can see it here in this lead as well. It's almost like the T wave here is a very broad, slowly changing signal that only goes positive, but here it goes in two directions. It goes up, and then there's a sharp negative deflection, and that negative deflection there is the P wave of this premature beat. You can see it in this lead as well. Now, where did this P wave come from? Well, since it's negative in AVF, it has to be traveling towards the head from the feet. It has to be going up somehow. And you can see it's negative in lead 2, but it's positive in AVL. So if lead 2 is going this way and it's going away from lead 2, it has to be in this half of the circle. So it's got to be in this region here because it would be positive in AVL. In other words, this beat most likely arose from the low right atrium and is traveling almost straight up towards the head. The PR interval of this premature beat doesn't look much longer than the underlying PR interval because the beat wasn't all that premature, and that's kind of what you'd expect. There is a compensatory pause, and then the patient's back in sinus rhythm again, until we see this beat, which is premature also, but in these leads, unfortunately, the P waves are not quite as clear as they are here in the limb leads. So this is a beautiful example of an ectopic atrial beat, premature, complex, whatever you want to call it, arising from the low right atrium that resulted in a P wave that clearly looks different, it clearly came early, and was followed by a compensatory pause. Okay, pretty simple. Well, here's an ECG that's a little bit more complicated. And when you first look at this, you say, oh, I know what this is. I can see group beating. Here's a group of 2. And then there's a pause, and then a group of 2, and a pause. And I remember the whole group beating thing when we were talking about type 1 second-degree AV block. Yeah, this might be winky back, right? Well, when we look for P waves, we can see this big giant P wave here with a fairly long first-degree AV block. Looks to be almost 400 milliseconds. And then in front of this beat, we see another P wave, and the PR looks to be even longer. So it's looking like AV block, but wait. Let's get out our calipers and make sure. So if we drag our calipers down and place it on the P wave, so here's the P to P interval, and if you move the caliper over to the next beat, you should see a P wave here, because after all, when you have second degree AV block, the P to P interval should be regular. And these P's are so huge, you really wouldn't be able to miss it. But it is not there. So this is not second degree AV block. What's happening is that this is a sinus P wave. It's up in 1 and it's up in AVF. And then you have a premature beat that occurs and then a compensatory pause. And then another sinus P wave, a premature beat, and then a compensatory pause. And it keeps repeating with a sinus and then a premature beat, and a sinus and a premature beat. So what did we call it when every other beat is premature? That's right, this is atrial bigeminy. And it's something that you see fairly often. It's more common in ventricular bigeminy, but a lot of people can be confused by this because they think that there's another P wave here that doesn't conduct, and it's often misread as winky back. But this is just another example of what can happen when a focus in the atrium starts firing prematurely and disturbs the rhythm. In the next video, we'll start talking about ventricular premature beats and how they differ from atrial premature beats. And then, of course, I'll try to pull it all together in the second half of this section. So, for the ECG Academy, this is Dr. Nick. Thanks for watching.